The prostate stands before the bladder. Do you agree with me? If you are looking at this whole picture from below, then you realize that this organ stands before the bladder. Do you agree to that? All right. So the word stand for is actually the Greek form of prostate. So the word prostate is taken from the Greek expression meaning one who stands before. One who stands before, which actually describes the position of the prostate gland. So this is the prostate. It is just standing before the bladder, because most people don't know about the prostate, but people are very much aware of the bladder. Everybody knows about the bladder, but it's telling you that before the bladder, there is a certain organ which is standing there, virtually, holding the bladder in position. All right, so stands before the bladder here is what brings us to the full meaning of prostate, taken from the Greek expression, one who stands before. So the prostate organ is standing before the bladder, so to speak. Right, you said that you are looking at the accessory sex organs, the organs that support the reproductive system, the male reproductive system. Now you've seen them one by one, and you realize that the prostate is the largest of the accessory sex organs. Okay. And like we've seen, it is located at the base of the urinary bladder, directly below. If you look here, it's just this is the bladder, directly below the bladder, you have the prostate. You are trying to look at the location. Okay, so anatomical location. All right, located at the base of the urinary bladder, in front of the rectum, and surrounds the urethra. So you see that, especially here, it is surrounding the urethra. This is the rectum. This is the rectum. So it is standing, it is located in front of it. It is very, very important to familiarize yourself with the location. All right. So it is around the urethra, just at the base of the, or below the bladder. Okay. And also in front of the rectum. Okay. Now, if you look at this very well, if you look at this picture very well, especially this one, if you look at this picture very well, as a whole structure, what mathematical structure, how can you describe this structure mathematically? You can tell me. If you look at this whole structure here, okay. Now, mathematically, what does it resemble?
This is a dissection of the prostate gland.
There's a dissection of the prostate gland. What I'm saying, that mathematical figure.
Pentagon.
Not really. I won't take the pentagon. But all of us know about the cone. You know a cone?
Yeah, cone. Yes.
And you see this one as an inverted cone. Do you agree with me?
Yes,
because
please.
the cone, this should be the base, and this side should be up, but this one has been inverted. So one of the descriptions of the prostate, you can describe it as an inverted cone. Do you agree with me?
Yes, please.
Yes, sir. So these are some of the things that we also, the shape is like an inverted cone, having the base above and surrounding the neck of the urinary bladder. So just look at here. So if it were a cone, a real cone, this should be the base. Okay. and this should be the apex. But it's like if you have a truck offloading, let's say a trip of sand, you see that it takes that shape, okay, that shape. As it gets down, it's rounded, but up is an apex. So that's a typical cone. But if you invert it, then the base will now go up and the apex will come down. So that's what we're describing here. And then the base now is now directly joined to the base of the bladder. All right. And then this apex, which has been inverted, now serves as joining the urethral sphincter of a source. So these are all descriptions for you to know exactly where the prostate gland is located. All right. So more pictures of this. You have your bladder, of course, the sperm duct is also the vas deferens. Remember, I told you that. Now, some people decide to call it sperm duct because, when you talk about the duct, it's a tube. That is the tube that actually carries the sperm from where it has been stored, which is primarily the tail end of the epididymis. It is that one that is the duct, that's the tube, which will transport it from here, from the point of manufacture to, let's say, point of use. Okay, so that's why some people call it the sperm duct, but also the vas deferens, which is also the ductus deferens. We've talked about all of that. Of course, the penis, the ureter, everything is here. And you are going to see the prostate gland here. All right. Look at the position of the rectum. It's very, very important. You're going to see something. Look at the position of the rectum. Now, if an individual, okay, a male, bends like you are doing doggy, assuming that you are doing a doggy and you were there. I don't know how to do the doggy too, but I'm told that you have to bend. Is that it? The ladies who do the bending, eh? Oh, you are not responding. I mean,
no, we know doggy. We know doggy.
You know it, eh?
We don't
Yes,
know.
we know doggy.
You know. Now, where is Nadia? Class rep.
Hey, please, I'm here.
You know doggy, eh?
Yes, I know.
So, assuming that you bend like you are doing a doggy and you are male.
Grandpa.
Hello? Yes, sir.
Some of us don't know what is it.
You don't know doggy. Go and see your class rep. You help you.
Okay, Grandpa.
So, yeah, so that's why we say that it's important to know the location and look at its reference to the rectum. This is the rectum. And if you have to bend like you're doing a doggy, assuming that you were a female, of course you're a male though, and you bend as if you want to be a doggy. What happens is that now this rectum will lie on the prostate. So let's see here. So if you put your hand, if you bend like you're doing a doggy, and you put your hand into the rectum, okay, you are able to touch the prostate. Okay, so the rectum is behind the prostate, making it possible to feel the gland from the rectum using the finger. So, and this is what any physician, especially a urologist, if you want to examine your prostate, the procedure is called digital rectal examination. Digital, the fingers. You know that fingers are also called digits. So, and you are putting your digit, of course, your finger, into the rectum for an examination. All right. So that's what we call DRE, digital rectal examination. So any urologist, I mean, even ordinary physician should be able to do digital rectal examination once you want to examine your prostate. That's the first thing they will do. So you put your finger, they ask you to bend down, and then they put your finger into your rectum, and it is just because of how the prostate is located. Its position is very close, it's just behind in front of the rectum. So as soon as you bend, okay, and you know that the rectum too, as it is getting outside, it also has an ampulla. You know, whenever any tube enlarges, that portion becomes an ampulla. So this place is large enough. All right, and so you put your finger in it, and then of course you must be taught. And like you're saying, we are not doing the clinical aspect, that we have to just know some of these things, so that because we're going to see how something like this procedure impacts on, let's say, your PSA examination. As we move along, you're going to see the prostate, the PSA gland, the PSA, which is the laboratory area, how people do PSA, and get wrong results for patients. All right, because the lab didn't take some certain precautions, for example. And as we move along, you see what I'm talking about. So a doctor will first do the digital result, knowing the anatomical location of the prostate, and knowing the fact that once you put your finger, and I'm saying fingers are diggers, okay, not dig it as in 1, 2, 3, but our fingers are medically called diggers. And so if you put your digit, one of your fingers, into the rectum, because of the anatomical position, it makes it very convenient for examination. So the physician will do that, and then you will have an idea about the size of a normal prostate and how the texture, because it should be soft. It should be, once you touch it, it should be a little soft. It should give you, I mean, as you move your hand around it, it should give you a certain size. So you would know all that. So any good clinician will know that, oh, your prostate is enlarged, or your prostate is becoming hard, and therefore I'm suspecting, let's say, a cancer or something. Therefore, now go and do PSA. So that would be the first. It's like the first point where a doctor will look at a patient and will assess, will look at your feel whether you have a temperature, blah, blah, all those sort of things. Then he will suspect that you have malaria. Then he asks you to go and do a lab test. So this is the initial stages of examination that the clinicians do, the digital rectal examination. It's just a simple test examination. Now, so it gives you idea about the size and consistency of the prostate gland. And after which he will ask you to go and do a lab test or any other investigations. That's why it is important to know the anatomical location of the prostate and see how physicians use the location for this kind of examination. All right. Now let's look a little bit more about the structure of the prostate. Okay. The prostate is divided into 5 anatomical lobes. You see, even though as we have with some other structures, like the vas deferens, like the testes, like the seminal vesicles, they are all paired. But the prostate is not paired. The prostate is one. However, it's lobulated. When I say lobulated, that is, it has, as we were talking about the testes, you saw that the outer lining, which is the tunica abugenia, tries to push itself into the structure. And so it tries to, we call it invagination. I mean, you know, vagina. So when you are entering into a vagina, that's invagination. So it tries to push themselves into it. And as they do that, they tend to divide it, but of course not a complete division. And so it creates what we call lobes. So that's what is happening with the prostate. It's a single organ, but it is lobulated. Okay, so those lobes are technically 5. So we have 5 lobes. The entire organ is 1, not 5 organs, not five. It is 1, unlike others. But the lobes are 5. And one is called anterior, which is in front, posterior, which is at the back, and then lateral, that's size, and then median, the middle. So these are the lobes, and these are good for especially those who may be doing histology. Okay, you can have total prostatectomy where the entire organ has been divided, sorry, has been removed. Once it's been removed, you do the macroscopic examination, physical examination. You have to be able to describe the lobes, because any distortion in the lobes can also give you an idea about the pathological situation that is affecting the entire organ. Okay, so this is just an overview of the anatomical structure. All right, so it has 5 lobes: anterior, posterior, lateral, and then the median. 5 of them. Now, still on the structure, the tissue of the prostate gland can be divided into 3 different histological zones. Look, the first one was lobes. This one is histological zone. That we're talking about the tissue structure. So once you have this idea, you have tissue, prostate organ has been submitted to you, and then you do the cutting. Still in histology, you have a situation where you begin a slide, you have to do the examination and ask you to tell us what organ are you dealing with. So you have to know some of these things, and it's also still going to help you in your histological examinations. So we have the lobes, which is more or less physical examination. All right, we are here. You are talking about histologically the tissue, the nature of the tissue. That is 3. Okay, so we have the transition zone, the central zone, and the peripheral zone. You have to get a little idea about this, because sometimes you still must have an idea. The prostate may have a problem, especially in cases of tumors. You have to know which of these zones are more susceptible to cancer formation, so forth and so on. So that is why I brought this slide. So the transition zone, remember we have the transition zone, the central zone, and the peripheral zone. So we want to have more idea about the individual zones, what they do. So the transition zone found on the inside of the gland, okay, and surrounds the urethra. Remember, the whole organ is surrounding the urethra. So the portion which is inside, which is actually surrounding the urethra, is the transition zone. Okay, all right. It's the smallest part of the prostate, and comprises about 5 to 10% of the normal prostate volume. The only portion of the prostate that continues to grow throughout life and tends to undergo benign, which is non-cancerous or non-malignant hyperplasia. So that is why we are dealing with this one. So you have the prostate, which is enclosing the urethra. You know this already. Now, we are saying that histologically, tissue-wise, it's been divided into 3 zones. So the innermost portion is that area which is in close contact with the urethra. All right. So that small portion which lines the urethra, which is the transition zone, it keeps on multiplying. You see, and anything that keeps on multiplying has a tendency for hyperplasia. You know this already. If you have something which keeps on multiplying, then there's a tendency for hyperplasia. So that is where, let's say, a pathologist will look at a slide that has been prepared by the scientists. You look at it, you know where the urethra is, and then look at the zone, and then see whether there are any abnormalities there. Once there are abnormalities, they will tell you, oh, that this is BPH, benign prostatic hyperplasia, and not malignant. All right, good. And then you have the central zone. the central zone surrounds the transition zone. So you see that you are moving from the inside. Even though you are looking for the inside is not a central. The inside is a transitioner. So from the inside, you are coming to a next line, which is covering the second layer of the prostate that is lining the urethra, something like that. So that becomes your central zone. Okay, it surrounds the transition zone and the ejaculatory ducts. It makes up about a quarter of the prostate total mass. This is where the common duct to the prostate, the seminal vesicle and the seminal vesicles, so a seminal duct and seminal vesicles, ejaculatory duct is found. So these are all important information, especially for histological examinations. So that once you have your slide, the scientists should be able to also have a look at it. You don't just prepare a slide and you have no idea what it is, and then you send it to a pathologist. Then you are becoming an ordinary, excuse my language, technician, because the technicians should be able to do the work very well, technically, I mean, manually, whatever. The scientists should have more knowledge, science knowledge behind what has been done. So the only difference between the technical level and the science level is that the technical level is able to know how to do the thing. I mean, the technicalities, the procedures, and whether you're a scientist or not, you should be able to do that. Technicians are more trained by hands to be able to do that with just a little knowledge. So if you look at the knowledge, in my own listen, it's just about 50% of the science knowledge, and then also 50% of, let's say, the technical skills. Now, when we come to the science level, we expect to have a science knowledge of more than 80% and just about 20% of technical knowledge. And that's why sometimes you see those who don't know, if you are doing, let's say, the BSc or the MLSD, and then you go to a lab for attachment, you have a technician there who will tell you that, oh, and then it's like, huh. But you see, the thing is that the technicalities, the science level don't put too much technicalities on, you don't put too much weight on the technicalities, because once you have the knowledge, you should be able to apply it once you come back to the bench. So the training don't focus too much on your technicalities or technical skills. The training focus too much on knowledge, because once you have the knowledge, you are equipped. It's like when you are going to learn how to drive. I think they take you first and foremost to the classroom and give you that kind of basic knowledge. Okay, once you have enough knowledge from the classroom, they put you on the road and you are just going to apply what you have been taught in the classroom, and then you are good to go. What I'm saying is that as a scientist, you have more adequate knowledge. And then even the training is probably very little of technical skill. But because you have had enough advanced knowledge, when you have the opportunity, you'll be able to apply them. That is the trick. Okay. So all that we are saying is that if you're a lab scientist and you are in histology, you prepare slides, you don't even look at it. You don't do anything about it, then you push it to the pathologist. You are just becoming a technician. You have all been technician. I was a lab assistant before I moved to lab technician, before I moved to lab scientist. So I know I passed through all these things. What I'm saying is that at every stage, you must up your science knowledge at every stage. So all that you are saying here is that you are giving you some of this information. It may not be applicable in microbiology. It may not be applicable in hematology, but you may one day find yourself in a histology environment. You prepare, you take a slide, you can look at it. Oh, no, this is a prostate. This is a prostate gland. Look at this, look at this, look at that. All right. Just by the way, we move on, then the peripheral zone. So you see that now you move to the outside. You started from the inside, the transition. The next layer is the central, the outer layer is the peripheral. So mostly situated toward the back of the gland. It makes out the main body of the prostate gland, representing about 65 to 70% of the tissue structure. Incidence of acute and chronic inflammation in this compartment is high. Okay, malignant or cancer tumors in the prostate mostly develop in the peripheral zone. So what I'm saying is that if you have a pathologist, he's just looking at abnormalities within the prostate slide, and then you will just locate where the urethra is. So the zone immediately after the urethra, if there's any abnormalities there, it cannot be cancer. It's only a BPH. So look at that also. No, the abnormalities are just within the transition zone, and within the transition zone, you can only have BPH, benign prostatic hyperplasia. If you're having those malignancies or abnormalities in the periphery, the same thing that you saw within the transition zone, if you see the same thing in the peripheral zone, you consider it as a cancer. All right, so those are some of the things that I want us to look at. And the peripheral zone is mainly the area felt against the rectum during the digital rectal examination. Remember, we said that the clinicians, those who, especially the urologists, one of the first things they do as examination is the digital rectal examination, putting your hands into it. So which tissue do you think they will be feel? They will feel, the finger will feel. It's the peripheral zone, because the transitional zone is very deep within. That's where it is in touch with the urethra. The next layer is the central zone. You don't have access to it. So the zone which is outside becomes the peripheral zone. And that's where the physician can touch and feel it. And it should be soft. If it's hardened, then it means that there is a problem there. All right. I hope you are following, please. Hello.
Yes, Grandpa.
Are you with me? Okay.
Yes, Grandpa.
All right. Okay. So we are looking at the process size and shape.
Hello, sir.
Yes, sir.
Please, this is Kingsley. Can I ask some question here?
You are always welcome, please.
Okay, per the histological knowledge that we have gained here, I have two questions here.
Yes, sir.
The first one is, can we say that when a physician is diagnosing prostate enlargement, the focus is on the transitional zone, because that is where hyperplasia takes place?
Exactly. Exactly.
Okay.
And
if we are examining,
excuse me, that's when a histological slide has been prepared. But in the consulting room, he can only do the digital rectal examination, and he can only have access. He can only touch the peripheral zone. I hope that point is clear.
Yes, sir.
The only way you can have a view of all the zones, the transitional, central, and the peripheral zone, it's only when things have been done and you are looking at it histologically. I hope that point is clear.
And when there is a suspicion of prostate cancer and you have a tissue, that one you have to first focus on the peripheral zone, because that is where the malignancy happens.
Come again. If there's a suspicion for,
if there is a suspicion for malignancy like prostate cancer, and you have a tissue, that means as a technologist you should focus on the peripheral zone rather than other zones.
You see that sometimes that's why they request for multiple slides, because when you do the cutting, probably you will cut an area which has which has only one zone. Okay, so they will ask you to do more cutting. All right, so that you can have more slides which is depicting all the zones. I hope that point is clear. So
yes, sir.
For any tissue, especially the prostate, where you are looking, you want to look at the various zones. If you take one slide, unless you are lucky that one slide was cut in a manner that revealed all the zones, that one you don't have a problem. Otherwise, the pathologist will ask you to give you more slides.
Okay.
All right. Good.
Thank you.
You're welcome, sir. You just had light off. I hope that my battery will be able to sustain us to the end. All right. So we are looking at the prostate size and shape. Okay. It's always described as walnut size, and then approximately the size of a chestnut. Okay. So if you have that in mind, when the clinician is doing the digital rectal examination, he has that idea. So once he's using the finger, he's just having an idea about, and if you're trained, for example, if you have let's say some ejaculate or even urine, okay, urine, you want to do you want to look at the volume. As a scientist, you can look at, without even measuring cylinder, you can look at it and have a very good idea about what volume you are looking at. For example, if somebody, you take some amount of blood into you can look at the amount of blood and then estimate that this is likely to be about 5 mils or 2 mils. Once you have been dealing with volumes, that has been your hallmark. You are dealing with volumes all out. So that if you have something which is 300 mils, you should be able to, if you go to the markets, the women, those who deal with let's say corn, is it maize? Yes, maize and so forth, those that they have to weigh, even gari and rice. They tell you, oh, this is about olonka 3, without even measuring. This will be about olonka 3. I'm telling you, if they actually put it to measure, that olonka 3 will not be 4 and it will not be 2. It will always be 3 plus or minus just a little amount. So what I'm saying is that if you have a good physician who has an idea about the size of a normal prostate, you just feel it and they'll tell you that no, this is bigger than the expected, which is the walnut size or chestnut size. I hope that point is clear. Good. So, and it has to weigh 30 grams. So, but in situ, I mean, while the organ is there, you can weigh it. The weighing becomes possible only when, let's say, the prostate has been removed and then they weigh it, or even when you are in the lab. And this also still on histology. If they remove an organ and bring it to a lab, it is one of the requirements that you must weigh the organ. You must weigh it. Whatever organ that is submitted to you, the macroscopic examination will involve the weight. All right. So that's where the weight comes in. Otherwise, whilst it is in situ, you cannot know whether it's 30 grams or not. But it is supposed to be around 30 grams that if it's been removed. However, it's been known that with age, the size will begin to enlarge. And it is usually supposed to be normal. So benign prostatic hyperplasia, unless it is giving you any health associated problem, it should not be considered to be pathological. Okay, right. So that is it. So like you said, the peripheral zone is mainly palpable. Okay, and the posterior lobe is the part that can be felt through the rectal wall on the digital rectal examination procedures. This is just for, this is supposed to be for the physicians, but you must have an idea that how is the clinician able to know that you are likely to have a prostate problem just by inserting the finger into the anus and then making that examination. You will still be, if the person is very experienced, you'll be able to give you a lot of information about the possible state of the prostate. Now let's look at, so we look at the location, we look at the structure, and let's look at the functions. The prostate has various functions. The first and foremost is that it makes a contribution to the semen. Remember, we said that the semen, of course, you have the sperms which are produced by the testes, transported to the vas deferens, but as they come along, there are other accessory organs that also secrete fluids to add up to the sperms. to give you a complete semen. All right. And one of the organs that provides significant contribution by way of fluid is the prostate. All right. Remember, we said that the seminal vesicle produces a fluid that contributes about 60 to 70% of the entire volume. Here, we are going to have another contributor that's also giving us about 20 to 30%, and that's the prostate. So the prostatic fluid mixes with the sperm cells from the testicles and fluids from other glands to form the semen, which is then released. This is very simple to understand. The prostatic secretion, as I've said earlier, contributes 20 to 30% of the fluid of the total semen volume. Okay, so once you have 15 to 20% of the prostatic secretion accounting for the semen volume, and then the seminal fluid, seminal vesicles also producing 60 to 70%. It means that virtually the entire volume is contributed by prostate and the seminal vesicles. Now, the prostatic secretion or the prostatic fluid is slightly acidic with a pH between 6.5 and 6.2 and 6.5. Please take note. In some books, they will tell you that the prostatic fluid is alkaline. Please, it's not true. It is the seminal vesicle fluid which is alkaline, but the one from the prostate is acidic, slightly. Okay. Now, if you get to, if you have some old physicians, the old physicians, they are able to, if they want to check whether somebody has prostatitis, all right, they will do what you call prostatic massaging. And prostatic massaging will give you a fluid, which is essentially prostatic fluid. What they do is that, as we are talking about digital rectal examination, they put the finger into the anus and try to massage the prostate. You know, that can be done as if you are doing digital rectal examination, but rather they are able to massage the prostate. Once you massage the prostate, at a point, the prostate assumes that there's going to be it is sexual stimulation. Okay, now see, now the person is going to ejaculate. So the prostate begins to give off or secrete its fluid. So the fluid will come out through the penis. And then during the examination, during the procedure, somebody will be there to collect the fluid which is coming from the penis. Now that fluid is essentially prostatic fluid. The procedure is called prostatic massaging. And when you do prostatic massaging, the fluid that will come from the penis or the urethra is prostatic fluid. And that one, you check the pH and you know that it's acidic. All right. So that procedure, these days, people don't do it, but I just want to get you this information that you can do prostatic massaging to get prostatic fluid. You can use it for culture, you can use it for other procedures. I mean, especially once there is suspected prostatitis. All right, that is what they do. So that is just to confirm to you the fact that the prostatic fluid is actually slightly acidic. Then the prostate. Another important function of the prostate, to close up the urethra up to the bladder during ejaculation. All right, so you realize that the prostate is virtually a gatekeeper because we're saying that the urogenital tract, see, from the bladder coming down, the urethra is 7, a dual purpose. It is 7 for the exit of urine. It is also 7 for the transport of seminal fluid. All right. And the two cannot mix, because why do you think that the two should not mix at all? Why do you think seminal fluid should not mix with urine for any reason?
Hello,
Yes.
Grandpa. I'm
Yes, sir.
thinking because of the pH. The
Exactly.
difference
The
in pH.
urine is acidic, and we said that a sperm, cannot stand acidic environment for anything. The sperm cannot stand acidic environment. So anytime urine mixes with the sperm, it will kill them. To kill them one time. So if somebody produces semen and all of them are dead, sometimes you can also look at the mode of collection. Okay, if the person tries to go and use VV, and then immediately after VV, then he tries to also produce the semen. What will happen is that the urine residue within the urethra still has typical remnants of acid, and they can kill the sperms. All right, so that's just that way. So we're saying that the prostate is serving that dual function to ensure that once there is sexual activity, it will have to close up the entry. You see, it is the same entry point for urine, the same entry point for the ejaculatory duct. So they have to close up and through a sphincter. All right. So that's the function of the prostate, to keep it closed. So even if you are having a sexual activity and then you are feeling to urinate or wee, the bladder will not allow the wee to come. No, it will not do that unless there's a problem. Okay, and that is the actual function of the bladder, sorry, of the prostate, to close up the bladder during ejaculation. Is that point clear?
Yes, please.
Okay, all right. So here, in any typical anatomic situations, it is impossible to urinate and ejaculate at the same time. That's very, very important. So, but of course, if there are some anomalies, if there are some anomalies, that certain things can happen anyway. All right.
Definitely.
Okay. So, closing of the seminal ducts during urination. Okay, so you know that the seminal ducts don't contain sperms unless, of course, like you said, occasionally, sometimes you have some sperms being stored in the seminal ducts. You've said that already. But on a normal circumstance, that doesn't happen. That doesn't happen. So the prostate, one of the, and you know that the seminal ducts also open within the prostate. You know that the seminal ducts unite or join the ampulla or the vas deferens to give you the ejaculatory duct, which opens into the prostate. So the prostate has control over closing that duct during urination, so that you don't have also unnecessary sperms being produced into the urine. All right. Then some hormone metabolism. Remember, we said that the prostate is influenced by testosterone. Do you remember that? What
Yes,
it does is that the biologically active form of testosterone is dihydrotestosterone, DHT. Okay. So what happens is that the prostate itself has 5-alpha reductase. So the testosterone, once it gets into the prostate, what happens is that the 5-alpha reductase will now convert the testosterone to the testosterone. Okay, so in some labs, some doctors will request for DHT. If, let's say, a person who is supposed to be being adolescent, don't have hair, don't have the penis is still like a small boy or something like that, you request for DHT. All right. So because sometimes the testosterone level is normal, yet the person is not giving the what do you call it, expected secondary sexual characteristics. So the doctor will request for DHT, which is dihydrotestosterone, and that means that you want to find out whether the prostate is also working very well, because you know that some of the enzymes, some are biologically active, some are not. All right. If you do your let's say even the thyroids, okay, you know that some are bound, some are unbound, total and so forth and so on. So those that are bound, they become biologically inactive. To those that are so forth and so on. So this is what we are saying, that testosterone, the most active form of testosterone is dihydrotestosterone. But for it to be converted to dihydrotestosterone, the prostate must have the 5-alpha reductase, which will convert it. Okay, once it is converted, then you have your DHT, which will now be useful for the transformation or the development of the secondary sexual characteristics of the individual. I hope that point is clear. All right. So,
Hello.
yes, sir.
Hello, sir. I have some question here.
Yes, please.
With the principle behind the bladder sphincter muscle contraction and not allowing the urine and sperm to mix up.
Yes, sir.
Barely about 5 years ago, during service extension, I had a case and reported sperm in urine.
Okay.
And then my boss then told me that sperm in male urine was something normal, and it's not important for me to report such thing. And that time I was having a little knowledge about this weakened muscle. So I was trying to explain that the person was around 70 years. So I was trying to say that with a 70-year-old man, there is a weakened bladder sphincter muscle.
Yes, exactly the point.
Retrograde ejaculation, but then I was still being shut down that it's a male and there is no need for me to report sperm in urine.
Let me put it there. If it's occasional, let's say 1 or 2, you may leave it. But if it's significant, you have to report it.
Especially in old age.
Yes, it must be reported. Okay. And then the doctor will decide, because in old age too, the doctor also after 1 year, after you don't have to subject that person to any surgical intervention, because in those cases, then you may need surgical intervention. All right, then the doctor will look at it and say, even in prostate cancer, sometimes they look at the age and say, okay, is about 90 years and prostate, well, let's leave it, because the complications of the surgical intervention may even create even more problem. All right. So if the person is around 50, 60 thereabout, and then the clinician can decide to say that no, this is not, they can give you problems, and so let's try to do something about it. So you were right at that time, please. You were very, very right. Okay. All right. Can we move on, sir? Hello. All right.
Grandpa, please, I want to ask some question.
Yes, please do.
Please. You said that maybe if the person is old, we can record. Maybe what if the person is very young and you see sperm cells in the urine?
All right. The conditions will determine if, let's say, he had, let's say, sex the previous night, and then he's coming to do urine examination. There's some sperms in it. Sometimes you may ask, "Oh, did you have any activity last night?" You say, "Oh, yes, okay, don't worry." That one you may not need to. Hello, because you see, your interest in the lab is to find out a cause of a disease condition. Okay, so so you don't have to create an how do I call it? Yeah, I say it's not everything that you see that you report. Let me put it that way. So depending on the circumstance, if you see, if let's say you see sperm cells in the female urine, okay, and it's below age, let's say 10-year-old girl, 12-year-old, and then you have seen sperms in the urine of that young girl, you have to report. Because if you don't report, then you are covering up a crime of assault. Two things: either there was a case of, let's say rape, defilement, or a rape. You know the difference between defilement and rape? You know the difference between defilement and rape?
Yes.
Yes. So if it's underage and there's a sexual activity, whether it is of consent or no consent, it is defilement. If it's of age and it tells you that he didn't give you consent, but you had sex with the person, then that becomes a rape. All right. So if they also say rape, but it is underage, it still becomes a defilement. Even though sometimes the doctors will write suspected rape, and then you look at the age and let's say 12 years. That one is not it's not rape, it's the defilement technically. Okay, let me put it this way. So what I'm saying that the examination, the doctor did not give anything like suspected rape or defilement or anything. But you saw sperm cells and you look at the age, it's a female, the age is underage, you have to report. You have to report so that the doctor will not look at it. Yes, it's of no medical significance, but the doctor will now look at the social aspect of it and say, hey, small girl, you are at this age, the lab people are reporting that they saw sperms in this thing. It means that somebody did you report it or something like that? Then the doctor will also probably begin to also advise the patient so that that thing doesn't happen. So whether to report or not to report depends on a lot of circumstances. Please, are you with me?
Yes, please.
Yes, please.
To report or not to report depends on a lot of circumstances. So like I've said, if it's also an adult female and you know the person, you know that probably the husband is traveled. The husband is, you know the person. And then you do the urine and then the sperms inside. You will not report it, but you can also, especially if you know the person, you can, sister, I saw something, I didn't report it, but you see, this is what I saw that, blah, blah, blah. Then the person says, oh, thank you, I really, that kind of thing, then you can harm. But if the doctor is querying rape or something, that one, you have to report. If there's nothing like query of a rape or something, and you saw it, and it's an adult person, you don't have to report. But the other way too is that if you know the person, and especially, let me give you this joke. In the 1981, thereabout, when the revolution was in force, and there was a curfew, and by 6 o'clock you should be at your place. If otherwise, the army people, the soldiers, when they catch you, you see what they will do to you. And then there's this gentleman who was getting late. I mean, curfew was just about to catch up with him. Meanwhile, there's this soldier man who claimed that this guy is also chasing a girl he's interested. So it was just about 10 minutes to the curfew. And then the soldier man called the guy. And the senior boss asked him, but it's not time. Why are you getting this guy? So I know where he's staying. There's no way he can reach his house in the next 10 minutes. there's no way you will reach the house in the next 10 minutes. So
advance arrest.
So that is that. So sometimes it depends on let's say your relationship too with the person. If you saw sperm cells in a urine of a woman you know and it's of age, don't report, but you can also use it and then advise her about what you saw. Okay. So coming back to the old age, if there are few sperm cells occasionally, that one too you may not report. If there are many, it means that he's leaking sperms. If he's leaking sperms too, it means that once where he needs it most, during ejaculation, where he needs it most, a lot of the sperms will have been released off already. So it must be reported. There are other things too. Probably there's also somebody who has not also ejaculated for a long time. If it's a Roman father, where they don't have I'm told that they don't have to they have to be permanently abstaining from sex. Of course, they are human beings, so you get an offshoot of some sperms just going off. Okay, that one too it can be considered as normal in quote, and you may also not report. So to report or not to report, you have to use a lot of professional judgment. Are we free to go?
Yes, please.
Okay. All right. And then the prostatic secretion, is thin, it's milky white fluid, and contains components that make semen an ideal substance for sperm viability. What are some of the things that are in the prostatic fluid, prostatic secretions? Remember, I've said that you can have prostatic fluid being produced for laboratory examination. And that one, you require what you call prostatic massaging. It must be performed by the physician. Excuse me, my grandson is up now. Let me take care of him. Sorry. All right, thank you. I'm back. So, what are some of the things that are found in the prostatic secretions or prostatic fluid? There are enzymes. All right. And then those enzymes, you have prostatic acid phosphatase. These days, they don't do acid phosphatase in the labs. But we talk about it later on. But we have the acid phosphatase, but we have the prostatic portion. So we call this one prostatic acid phosphatase. And then you have, of course, the prostate-specific antigen, PSAs. You also have proteolytic enzymes. These are all from the prostatic fluid, fibrinolysis. And then we have minerals and organic elements, including citric acid or citrate, calcium, and zinc. They are all in some of the components of the prostatic fluid. We also have other proteins, including immunoglobulins, IgG, and IgA. All right. So just a little information about prostatic acid phosphatase. Acid phosphatase goes with alkaline phosphatase. They do the same thing. Okay. Now, but when we are dealing with enzymes, we have the optimal pH for activity. So the acid phosphatase, their activity is enhanced in an acid environment, whilst in the alkaline phosphatase, the activity is enhanced in an alkaline environment. That is it. But you are very familiar with ALP, alkaline phosphatase, especially when we're dealing with the liver function tests. Of course, ALP is there, and that is the alkaline phosphatase. You have acid phosphatase. Like I've said, it works the same principle. Laboratory detection of alkaline phosphatase, the same thing as acid phosphate, except that one, your pH for detection should be acidic, and then the other one, your pH for detection should be alkaline. That's all. But their substrate and everything will be the same. Okay, right. So it helps neutralize acidity of the vaginal tract. Like remember, we said that because the vaginal cavity is of great concern to us, because at the end of the day, the production of sperms is towards fertilization and for production. Okay, and so they must find themselves in the vaginal tract, and because of acidity, there must be a lot of things that should be available to suppress the what do you call the acidity of the vagina. So somebody will ask me, but the vagina is already acidic, and so if you have acid phosphatase there, how does it neutralize the acidity of the vaginal tract? But you see, you are talking about enzymes that uses up acid. Okay, talking about an enzyme that uses up acid. So once it is using up some of the acid, in effect, it is neutralizing the acidity of the vaginal tract. I don't know whether you're getting the point. This is an enzyme that uses up acid. Okay, so its presence alone is going to use up a lot of the, let's say, the free hydrogen ions in the vagina. So by taking up a lot of the free hydrogen ions in the vagina, what is happening is that it is rather reducing the strength of the acidity in the vagina. That's all. So don't say that, because this also acid phosphatase, how does it neutralize acidity in the vagina? I hope that point is clear there. Okay, so by so doing, it helps to make the environment favorable for sperm motility and survival. Serum acid phosphatase was historically, this is what I want to bring to your attention. Historically, that is in time past, it was used to detect prostate cancer. Okay, so it was once widely measured as a biomarker for metastatic prostate cancers. But because of the advent of prostate-specific antigen PSA, now it has made the use of serum acid phosphatase almost useless because it is non-specific. Okay, it is non-specific. But at that time, PSA was not in the system. So all doctors, some of them will still be requesting for acid phosphatase. And if they don't write acid phosphatase, they write ACP. They come to a lab, you'll be confused. So the ACP is the acid, that's a short form for acid phosphatase, just as you have ALP for alkaline phosphatase. All right. So that
Grandpa.
was, yes, sir.
Please, so I want to ask some question.
You are welcome, sir.
Please, studies have also shown that the PSA, which is the prostate-specific antigen 2, is not specific.
Yes, we'll talk about that. But I'm trying to compare the ACP and the PSA.
Okay.
The ACP there, it was not. But at least in the absence of nothing, they say in the absence of nothing, bad is good. That's not a good thing anyway. But in the absence of nothing, bad is good. So in the absence of the PSA at that time, we are talking about historically. In the absence of harm. So the acid phosphatase was being used. But PSA came in, and comparing PSA and acid phosphatase, PSA was far more specific. However, as
Okay.
you move along, you also see the limitations of the PSA. Is that all right?
Okay, doc.
Okay, good.
Okay, thank you.
So those times, elevated ACP was used as a marker for prostatic lesions. Okay, so I'm saying that if you meet some of the old doctors, they will still be requesting acid phosphatase. All right. So that is about the acid phosphatase. So we now come to the prostate-specific antigen, the PSA. It's an important enzyme, of course, the serum protease. And because it's a protease, what it means is that they can also help with the thinning of what? Semen. You see that it's a protease. It means that it can lyse protein, some serum containing proteins. And therefore, by lysing them, it amounts to thinning or making the semen thinner. Remember, we said that, yes, immediately after ejaculation, semen will have to clot. Okay, but after some time, the clot will have to be liquefied. The clot will have to decoagulate and liquefy. Okay, and even become more thinner. So that once it become more thinner, the sperm become more freer to move. Okay. And the presence of the PSA is a thinning agent because it is a proteolytic. All right. So it can break down some of the serum containing proteins and then make the whole ejaculate or the whole fluid more thinner for sperm movement. So PSA helps liquefy semen after ejaculation. All right. Remember, you also have the fibrinolysis there, which that will also do, but the PSA is supporting that activity. It's involved in lysing the ejaculate clot with seminologin as its substrate. Remember, we talked about seminologin as also being produced from the seminal vesicles. You remember that? So now you have the seminologin as a substrate. Okay, so it means that these are proteins that contain serine, and then the PSA is a serine protease, break down serine containing proteins, and so that's how come they're able to contribute to the gel dissolution. All right, okay. So they contribute to gel dissolution in freshly ejaculated semen and helps make the semen thinner and more fluid, allowing sperm to be released. I hope that point also explains what I've said already. So let's look at the clinical use of PSA. So clinically, PSA is the most successful and widely employed cancer serum marker in use today. Okay. Now, PSA is now routinely recommended as the primary screening parameter for prostate cancer. The prostate cancer, some will shorten form, some will write it as PCA, some will also call it CAP. CAP, C-A-C, a big C, small a, and a big P, CAP. That's cancer of the prostate. Okay, so if you see some diagnosis as PCA, it's either prostate cancer. If you have the CAP CAP, it's also cancer of the prostate. The same thing, depends on the physician, but you have to know that sometimes this is the way the clinicians abbreviate prostate cancer. So it is used as a standard parameter for pathological investigation for men over 40 years. PSA has severe limitations for prostate cancer detection due to its limited specificity. So we come to where it has limited specificity. I mean, it is not specific. So even though PSA is organ specific, because it is only the prostate which specifically produces the PSA, because it's a prostate specific antigen. So it tells you that virtually no other organ produces the PSA. So it is organ specific, but it is not cancer specific. That's where the problem is. You see that we are usually using it as a
Grandpa.
marker. Yes, sir.
About the please about the organ specific of the prostate.
Okay. Is there any new information?
Yeah, when we were doing histopathology.
Okay.
The lecturer was giving us a scenario where PSA was found in the mammary gland of a female.
Mammary gland of a female.
A female.
Of a female.
A female, yes. He was standing on that to see that PSA is not organ specific as such.
All right. So what I would say, I will not challenge that because probably of where the information. You see, you can also read further and know that there's a certain organ called skins.
Okay.
In female, which is supposed to be an analogy or a homology to the prostate.
Okay.
You know that technically, females don't have prostate. You know that.
I know.
But there is an analogous organ which is also located the same way under the bladder of the female.
Okay.
And it is called, I'll check on that, but other skins or sickins or something like that. I've forgotten a little bit. The name is tomorrow I'll cross check on that, but other sickins or skins or something like that, which is just like when we're talking about the clitoris and then the penis. You see that it has been determined that a lot of things that make up the what do you call it, the clitoris, are also present in the distance, and therefore you know that we have the penis erect, but the clitoris also erect using the same physiological principles as is used in the penis. So we have erectile clitoral erection. Okay, we have clitoral erection.
Okay.
But technically, we don't have, the female doesn't have a penis. So what I'm saying is that I'm not disputing or discounting what your lecturer said, but what I'm saying, that what I know for sure, that there is an organ, which name I've forgotten, but it is sickins or skins or something, which I said I'll find out.
Okay.
It is also assumed to be performing the same function as the prostate in the male. And so I'll not be surprised that it is also producing, because they are homologous. I mean, it's like the same thing. They may also be producing. Otherwise, why should PSA be present in
a woman,
in a female? Otherwise, then because the name is specifically prostate specific antigen. Then what is in there? We know that females don't have what do you call it? Prostate. So why are you calling that one to also PSA in the female? So I will not doubt it, but this is, so we are all scientists. Sometimes you need to also critique the information that comes to you.
Okay.
Okay. I wouldn't say that I know much, but what I'm saying, that PSA, even the name alone should tell you that apart from the prostaglandins, which I told you.
Okay.
We said that prostaglandins technically, historically, was thought, in fact, initially it was known to be present in urine, in the semen, but they didn't know which specific organ was producing it. And then at that time, it was assumed that it was coming from the prostate, and so it was called prostaglandins. Later on, it was confirmed that no, it is not coming from the prostate. It was rather coming from the what do you call it, seminal vesicles. But the name has remained. All right. So sometimes some of those things can happen. But with this one, prostate specific organ, as far as I know, it is specifically for the prostate. And since females don't have prostate, they could not have had PSA. But if that is also true that they had a PSA, then can we look at the homologous organ, which is playing the role of the prostate in the females?
Okay.
So let's all check on that, and tomorrow, no, we are meeting on Thursday. Thursday when we meet, we can dialogue on that. Is that all right? Good. I like the interaction. What makes it limited is that it is not specific for cancer. But meanwhile, in previous times, once you do a PSA and then the PSA is high, straight away they confirm that you have cancer, and then, but that is also not true. All right. So, and it's found in several patients with non-malignant conditions such as benign prostatic hyperplasia, BPH, and also in prostatitis. You've seen that. So you see that it cannot be specific for cancer, because when you have BPH, BPH is not cancer. It's not malignant. It's not a tumor. But if you have BPH, you can still have high. Yes, sir.
Grandpa.
Yes, sir.
So what you were saying was the homologous of the PSA structure in a female is the Skinner's gland.
Okay. Thank you. Thank you. So I was thinking,
also known as the paraurethral gland.
Very good. So what I'm saying is that I didn't know much about what you were saying, but what I knew for sure was that there is a homologous organ in the female, which has been likened to the prostate in the male. Okay.
Sure,
so fine for the checkup. Thank you very much.
Mm.
So the name again is what?
Yes. SKENE.
Yeah, okay, scanning. So yes, I remember it was seconds or something like that. So thank you very much. Thank you very much. All right, so you move on. So elevated serum levels of PSA is often diagnostic of prostatic diseases. So the best you can say that when you have elevated PSA, you can say that you have prostatic disease, but you can't say that you have cancer or prostate cancer. That would be very, very dangerous. Also, however, other conditions such as severe constipation. So as scientists, let's take this portion very, very seriously. So we know that when you have elevated PSA, yes, you don't want to say that you have prostate cancer, but it is right to say that you have a prostatic disease condition. However, if you have severe constipation, is it a prostatic disease condition? Of course, no. But it has also been confirmed that if you have severe constipation, you could have, what do you call it? You could have elevated PSA. The principle here is that we know that when you have constipation, sometimes you have bulky stool locking up in the rectum. And remember, we said that the rectum, the prostate is just in front of the rectum, and therefore they can impress on the prostate. So any manipulation of the prostate will also, remember we said that we can have a procedure called prostatic massaging, where as you put your finger into the clinician put the finger into this and you massage this and you see semen, let me call it semen, because whatever will be coming out is like look like a semen, and people think that it's not semen. This fluid is specifically coming from the prostate, and it's called prostatic fluid. And the procedure is called prostatic massaging. So what you're saying is that any manipulation of the prostate will cause the prostate to release prostatic fluid. And then you know that PSA is also very high in the prostatic fluid. So if you have severe constipation and then you go and do PSA, it will go high. And once it goes high, the general impression is that you have, because before the doctor will ask you to go and do a PSA, you already is suspecting that you have, let's say, prostate cancer. You already have that suspicion. So if you go and then come here, and if you go and bring in a result which indicate elevated PSA, straight away, you know, he said, okay, I suspected it, and therefore you have it. Either you ask you to go and do MRI or biopsy, or even the what do you call it? Even the kind of stress that will come to you as a patient, that alone is enough to bring you down. If the doctor tells you, though, I'm suspecting that you have prostate cancer, and your first lab report is giving you elevated PSA, and so probably that alone, the stress that will come to you is nothing to joke about. So,
Grandpa,
yes, sir.
Please, some doctors too normally will send patients with hernia to go and do prostate. Does it have any correlation?
Patient with a hernia.
With hernia, yes.
Oh, I don't know. I don't know why, but probably they want to rule out any prostatic involvement. I don't know. But non a PSA is technically for prostatic disease conditions. So if you have hernia, it has nothing to do with the prostate, but probably the patient has hernia, all right, but he's also old, a little bit old, around 50 thereabout, and you want to rule out something like that. All right. Once we get to Andrology 2, where you'll be doing cryptorchidism, so forth and so on, we'll talk a little about the hernia and why it's common in males. I think I tried to mention a little bit. We talked about the fact that the embryologically the testis is developed in the abdomen, and then they descend through the inguinal canal. So once they descend, they create a hole there. The hole will automatically heal. But once it heals, something that will heal there, in future, if there's pressure on it, it will give way. Once it gives way, then we get the herniation. All right. So we will talk about those things once we get there. But we are saying that let us be mindful that once somebody has severe constipation and you do PSA level will go high. Once it go high, the doctor, before the doctor asks the patient to come and do PSA, he's already suspecting that he has a prostate condition. So your elevated PSA level will not be, the doctor will not think even about constipation. Okay, he will not think about the patient having constipation. No, already he's suspecting that the patient has a prostate condition. And if you don't rule out, let's say, the severe constipation issue, and then we come to the lab and then you also did it, what will happen is that you are going to have elevated PSA, and therefore it will lead to misdiagnosis. All right. When the patient have acute urinary retention and you do PSA, it will go high. If the person has ejaculation, if the person has sex the previous night, of course, technically, any ejaculation, even if it's not sexual activity through sex, and it's just like wet dreams, and there was that ejaculation. Once there was ejaculation, the prostate has been activated, and therefore PSA will go high. Extended sexual intercourse. You see, ejaculation is where the person is releasing the semen. What if sometimes some men, they will go into sexual activity, and for 30 minutes to 1 hour, he has not ejaculated. He has not ejaculated, but the woman says, oh, please, I'm tired. I can't go any longer. So yes, the person has not ejaculated, but that extended sexual activity has also compromised the integrity of the prostate. And therefore, if you go and do PSA the following day, you are going to have high elevated PSA. Prostatic manipulation, such as the DRE, the digital rectal examination. If the patient went to a doctor and then the doctor did the digital rectal examination, so I'm suspect that I did the examination. I think that I want you to go and do a PSA. From there, from the consulting room, the following day or even then, he goes to the lab. Doctor has written PSA. You go and do the test. Technically, the result will go high because the prostate has been irritated or manipulated. Okay, even if you see, when you drive or when you are on a bicycle, so somebody is coming to do PSA. He's staying far away, some, let's say, some 30 minutes drive somewhere, but he decides to come to hospital on a bicycle. Such a person, once you're on a bicycle, what happens is that your perineum is directly on the back seat, and it puts a lot of pressure on the prostate. And so as you drive, that kind of exercising cycling. If you come and do PSA, no, automatically your PSA will go high. So these are the things as lab scientists you should know, so that we don't unnecessarily produce results that will later on turn out to be normal. Because if you also have a good doctor, and then it tells, okay, I want you to go and repeat the test somewhere else, but the conditions that cause your PSA to elevate, let's say the person was on a bicycle and then cycled for about 30 minutes before coming to your end, and you didn't know, you also didn't ask, and then you did your PSA. But the next time the doctor asked the patient to go and do it in another lab, he was not on bicycle. Okay, it was just probably that lab crowd was close to him, so he just walked to the lab. Once that person goes to the lab in that laboratory, the PSA will be normal. Then he comes back to you and says, oh, you have produced a bad result. So these are some of the things as lab scientists you should know, that yes, PSA is good, but because there are a lot of limitations, so you must, as lab scientists, try to minimize the involvement of the limitations as much as possible. So if let's say patient is coming to you for FBS, so won't you ask the patient whether he has eaten this morning? Sure, you ask. So if a patient is coming to do PSA in the lab, you have to ask, oh, have you had sex in the last, let's say, 48 hours? If you say yes, then you can just advise or counsel the patient that once you do that, once you have had sex in the last, let's say, 48 hours, if you do the test for you, the PSA is likely to go high. It might not be due to the condition the doctor is expecting, but it might be due to your sexual activity, which is normal. Anybody, you are free to have sex, all right. But because of this test, you ought to have abstained from sex for about, let's say, 2-3 days before you come and do the test. That would be fantastic. But we don't ask any questions. We don't do anything. Just because the doctor has requested for PSA, the patient comes in, you just take the blood. You give the results, and then it's always high. Okay. Once it is high, the first indication is that the patient has prostate cancer. The doctor will want to confirm. So we'll ask the patient to go and do either biopsy or MRI and look at the cost and the inconvenience and then the stress the patient will have to go through in doing MRI or testicular biopsy. Why must we or prostate biopsy? Why must we subject patients to that kind of inconvenience? So yes, we are doing all this so that you also take caution in such circumstance. I hope that point is clear. Right. In addition, other factors such as body weight, carbohydrate intake, and insulin resistance can all influence serum PSA levels. So you must consider all these things in your PSA so that the results will not unnecessarily be misconstrued for prostate cancer. Okay. Then we're still talking about some enzymes that may be present in the prostatic fluid. Fibrinolysin, as the name sounds, lysin means breaking. Fibrin, okay. You remember that we talked about fibrinogens in the seminal vesicles. All right, so fibrinolysin will try to break them down. We remember that we said that the components of the seminal vesicles will facilitate or initiate or help in the ejaculate clot. All right, so it is the components of the prostatic fluid that will also now decoagulate or liquefy. Okay, so the two work against each other. This one is causing this to clot. This other one is also breaking down the clot. All right. So this proteolytic enzyme, which is the fibrinolysin, secreted into the semen, act to break down clotting factors in the ejaculate and help dissolve the seminal fluid coagulum after ejaculation, allowing the semen to remain in a fluid state and be able to move throughout the female reproductive tract for potential fertilization. I think that is also self-explanatory. There are other minerals and ions that are also found in the prostatic fluid. They include citric acid, sodium, potassium, magnesium, calcium, zinc. So all these things, these are ions, and so they give a slightly metallic nature to the seminal fluid. Of course, because you have sodium there, potassium there, so they also give it a salty odor and contribute to the overall smell of the semen. I remember yesterday somebody was asking me, so what accounts for the smell of the semen? So you see that technically the smell is technically coming from the prostatic portion of the seminal fluid. All right, seminal fluid have a portion being contributed by the prostatic fluid. Okay, and because the prostate has all these things, they tend to influence the odor, and for that matter, the smell of the semen. But more importantly, before we end, apart from the metallic component, there's this spermine, which actually is a booster to the smell. Okay, so we'll go back, but I just wanted to add that. But I'm saying that all these, the citric acids, sodium, potassium, magnesium, calcium, and zinc, which are all present in the prostatic fluid, they create the metallic aroma, so to speak, and then a salty odor, all of which will come together to give the overall smell of the semen. But like I said, another component, spermine, which will go there, is also a key contributor to the smell or odor of seminal fluid. And so in effect, in response to the question that was raised yesterday, which I said, let's wait until today, you see that the prostatic fluid is the highest contributor to the smell, right? So we saw that with the minerals, we talked about citrate, potassium, blah, blah, blah. Let's take a few of them and see their role. The zinc, the prostatic gland has the highest concentration of zinc in the body, about 100 times higher than the serum zinc concentration. So that is that. Why must we have a lot of zinc in the prostate? Remember, the prostate is controlling urine and prostate at the same urine and then seminal fluid at the same time. So it is subject to infection. All right. Urine is coming in. Sometimes there could be bacteria from the urine that is passing through the urine, the prostate, and blah blah. So the prostate is susceptible to infection, and for that matter, the zinc there is supposed to be antibacterial. Okay, it's like antibiotic of a sort. So zinc in the prostate has important bacteriostatic properties that functions as antibacterial factor. So you see that it has a high proportion of zinc. So the zinc there is protecting the prostate against any infection. All right. So that's the nature. That's how God works. He knows that this organ is going to be exposed to potential sources of infection through the urine and through the seminal vesicles, through the semen. So if you don't give it, protect it by way of certain components, that organ will break down so early. So that's why zinc, you see that the first line is saying that it is the highest concentration of zinc in the body. And zinc has antibacterial, antimicrobial influence. Okay, and therefore it is protecting the prostate against infections. Also, within the seminal plasma, zinc serves to stabilize chromatin within the sperm head. All right, but the most important is the protecting the plus the prostate against infection. All right. So citric acid, which is citrate, provides energy for sperms and also inhibit premature capacitation of sperm. And then most importantly, spermine is not part of the minerals. It is a hormone-like substance, and it is polyamine, a positively charged organic molecules that have 2 or more amino groups. So that's polyamine. All right. And it is this one which is actually producing the odor. So the prostate gland has the highest concentration of spermine in the human body and mostly ensures sperm motility and imparts unique odor to the semen. So you have spermine, which is giving you that strong amine. You know that polyamine, amine has that kind of bleach-like, like an ammonia of a sort, bleach. So you know that sperm have that kind of odor. All right. So, and you know that spermine is polyamine. So that gives you that kind of strong smell. So this one, coupled with the other minerals we talked about, the sodium, potassium, magnesium, all those things, that together gives us the overall smell or odor of the semen. All right, so that brings us to the end of prostate as much as possible. Then just some few slides on the bulbourethral glands. So the bulbourethral glands, also called the Carpus glands, is located deep perineal pouch. Perineal, as we said earlier, that space between the anus and the scrotum, that's the perineal. So deep within there, that's where this bulbourethral gland is located. All right. So, and then posterolateral, posterior above and then lateral side. So above the side of the urethra. And so once you see, you have the prostatic urethra, you have the membranous, and then you have the spongy, urethra, as we did earlier. So you see that the bulbourethral gland is here, but the duct, and you said that for every gland, there must be a duct, that's the tunnel through which the fluid will go. So the duct is taking the fluid from here and then taking it into the spongy side of the urethra. So that is the bulbourethral gland. All right. So the bulbourethral gland is paired and pea-sized gland. The ducts of the Carpus glands open into the spongy urethra, like I said earlier. So this is the gland, and this side is the duct, or yeah, that's the tunnel or the duct. So it is this one which will now open into the spongy side of the urethra. All right. So once they come, so it means that this one will not come back to the prostate because it is now lower the urethra. So this is the prostate. This is down here. So its fluid will just move straight away and will not be part of the prostate. So as we move along, you see that this one will come first. And before this, the sperms, the seminal vesicles, fluid, and all those things coming in will be mixed up within the prostate. All right. So this one will come on its own before the actual fluid is coming. So we call this one pre-ejaculate. The fluid, the ejaculation, the fluid coming out is called an ejaculate. The process is ejaculation, but what comes out is the ejaculate. The semen that comes out, the entire volume is called ejaculate. So before they come out, this portion, the bulbourethral gland, will give its fluid. So the fluid will just come ahead. It's like a president is coming. So the what do you call that one? Who can tell me? The advanced, what do you call that one? The advanced team or something. When the president is coming to town.
You mean the convoy?
the convoy, or there's an advanced team that will come. So this is like the advanced team. They will come out. You're also going to see what they are also part of the semen, but they will come out first. All right. When they come out first, then the rest will follow. Let's see how it works. So the bubble urethral gland also produce a clear, lubricating, mucus-like secretion containing glycoproteins that's released into the urethra during sexual stimulation. This fluid is slippery and is released prior to ejaculation, hence the term pre-ejaculate. So like I said, before the main seminal fluid comes out, this one will come out. It's called pre-ejaculate. It performs a lot of functions. Let's keep note. Now, the fluid helps neutralize the acidic environment of the urethra and provides lubrication for the urethra before ejaculation. This fluid helps flush out urine and debris from the urethra. So going back, he's saying that the main seminal fluid is being prepared within the prostate, because within the prostate, the sperms have come in, seminal fluid, seminal vesicle fluids have also come in, and then the prostatic fluid also, they are all going to be mixed up within the prostatic urethra in the prostate. And then before they will come out, this one will come out in advance. That's why we call this one pre-ejaculate, before the main ejaculation. So this is pre-ejaculate. And as we move along, you see that this one, the fluid here, is also alkaline. And remember, we said that one of the factors that can succeed in killing or inactivating sperms is acid environment. And we said over and over again that this whole urethra has an acidic residue because urine is usually acidic. And most times, all of us know that you will pass urine more often than anything. So there will be urine residues along the tract, and that makes the urethra acidic. So this gland is producing this mucus fluid, which will come out and is also alkaline. So one, to also neutralize the urethra, to neutralize the acidity of the urethra, awaiting the main semen coming. Again, it is also slippery. It's mucus and slippery. And what comes out, because it will come out first, it comes out and also flushing out any debris, any dead cells, or any bacteria along the way. This one is flushing it out. Now, one important thing which all of us must take note, because it's slippery and it's coming out, many times it will get to the tip of the penis. And let's see what happens to that. Okay. But before that, the pre-ejaculate accounts for less than 1% of the semen volume. Remember, we said that with the semen, we have a portion being a component of the sperm cells themselves. It's like when you have blood. Okay, the cellular component, if you spin, and that's what they do in PCB, pack cell volume, you pack the cells. So the cellular component will take a certain what we call a fraction, and then the fluid portion will also take another fraction. So the pre-ejaculate, by way of fraction, is just less than 1%. And remember, you know that the sperm themselves will take a certain fraction, and then the largest fraction is coming from the seminal vesicles, and then the next one is also the prostatic fluid, which is also taking about 20 to 30%. So once this one is taking 20 to 30%, this one is taking about 60 to 70%. It means there's the cellular component and then the pre-ejaculate portion is just something, nothing to write home about. But yes, they are playing important role. All right, so the pre-ejaculate accounts for less than 1% of the seminal fluid. While generally considered a minor contributor to the overall semen volume, the bulbourethral gland secretions are vital for proper urethral function and sperm viability during intercourse. I think that point is clear. that yes, the volume which is coming is small, but the role they are playing is very important because they are going to clear the any debris along this track, and they are also going to lubricate it so that, and because they have that kind of mucus or jelly-like consistency, it makes it serves as a lubricant. So once the sperms are coming or the fluid is coming, because this place is lubricated, it will give the free flow. All right. And then importantly, I'm going to get there. The pre-ejaculate serves some important purposes. Serves as lubrication medium for the urethra and the tip of the penis. I think I've mentioned this one. Because it is jelly-like, because it is mucus-like, it is slippery. And because it's slippery and is clearing the mess within the urethra, it makes as like lubricating the urethra. Once the urethra is lubricated, it makes the flow of semen very, very smooth. Again, it comes out through the urethra. You know that the urethra opening is the meatus. So the ejaculate will also be at the tip of the penis. Look at what it does. The mucous component of the secretion at the tip of the penis helps reduce friction during sexual intercourse, making the process more comfortable and efficient. You see, sometimes some ladies will tell you that, oh, even before he penetrates, okay. And some men too, out of ignorance, they also say, okay, even I've not even penetrated, but yet remember, that first fluid that is coming is not actually part of the ejaculate. It's pre-ejaculate. Remember, it is preparing the road for what do you call it? For the main ejaculate, main seminal fluid, because you said over again that the urethra itself is acidic. Acid is injurious to the sperms. So this pre-ejaculate is coming even before you have any sexual arousal. Let's say you have seen the woman and you are doing that kind of, sexual interaction. Before you could say Jack, you will see that the tip of your penis, there's some fluid there. That doesn't mean it's a woman, but that is the pre-ejaculate. It is preparing the urethra for the flow of the main semen. And it has been designed in such a way that once it comes to the tip of the penis, and because it is, what do you call this? It serves as a lubricant. So once it serves as a lubricant, it helps in penetration. You know, sex is penetration. You see, so if you assume that what is coming is there, then you are getting everything wrong. That is normal physiological activity. It has to come to serve that purpose of neutralizing the urethra and also helping in your penetration, because it makes the tip, it comes to the tip of the penis, and then it serves like a lubricant. And so it facilitates penetration. And for you to enjoy your sex and then have it in a more comfortable mood. So it is very, very normal, very, very, very normal. The women who are going to the studies, you must know that. Don't say, oh, penetrate pre-ejaculate. That pre-ejaculate is serving a dual purpose, clearing the urethra, making sure that the urethra don't harbor any traces of urine residue, and also to make the urethra lubricated so that once you are going to have ejaculation, they will come out freely. And most importantly, also coming to the tip of the penis. Once it comes to the tip of the penis, it facilitates penetration for you to enjoy your sex. Thank you. Right. So like you said already, it also expels any residual urine. Remember that the urethra always will have residual urine. Okay, so it expels that one. If there are any dead sperms, dead cells there or mucus there, it also does that one for you, and preparing a clean and lubricated pathway for ejaculation. Again, you said that the bubourethral glands, the fluid there is also alkaline. And of course, because alkaline, it neutralizes any residual acidic environment of the urethra and create a more favorable environment for sperm transit, protecting sperm from damage and enhancing medicine. So, ladies and gentlemen, that brings us to the end of our session today and also the end of module 1. Thank you very much. God willing, Thursday, we're going to start module 2 and we're going into the normal physiological activities that occur with, for example, the penis. So you're going to start with erections. We didn't start the penis erections, and we're going to talk about how erections happens, types of erection, and so forth and so on. We're going to deal with postmortem erection. Who has an idea about postmortem erection? Whether you've heard it before, postmortem erection. It means the person is dead, but there's what does that mean? If you're a scientist, you will say that, so I could for being and will you say that? So who has any idea about post-mortem erection? We'll deal with that, but I'm just giving you a whip up so that you know that we have interesting topics ahead.
Okay.
Anyway, that was just by the way. So that brings us to the end of our session today. And from Thursday, we start another module. So that will be module 2, and it will moving higher up. So we call it Andrology 2. Okay. So we finish with all those things before we move to Seminology. All right. Any question, please?
Hello, Grandpa.
Yes, sir. Yes, sir.
There's something I wanted to ask. With this model 1, model 2, is there going to be any small quizzes after maybe model 1 that
No,
you can
you
sharpen?
combine the model 1, model 2. The model 2 is also another aspect of andrology. Okay.
Oh, okay.
So we want to do that full exams on andrology.
On andrology.
Oh,
okay.
Then you have completed all.
Oh,
so,
okay.
Yeah. Okay.
That's fine. Thank you.
All right. You are welcome, sir. Any question, please? Are you enjoying the course?
Very well.
I see. Thank you. But you are one person pen or any from other sources. How are you enjoying the course?
We are really enjoying it, Grandpa.
Okay. Nadia.
Grandpa is very, very educative.
Nadia, how are you enjoying it?
I'm really enjoying the lecture, and I really like the way you're even making it easy for us to understand.
Thank you.
Yeah.
But you didn't mention the doggy aspect. That's why you didn't. Okay. Good night, ladies and gentlemen.
Okay, good night.
Happy meeting you.
Night.
Oh.
Okay. All right. Hello. I think somebody put on the chat from please, what means that the seminal fluid or semen get into the urethra? Oh, okay. So I'm saying that you will do seminology and all those things will come out. Okay. So don't worry. All right. So once again, good night. See you on Thursday.